So good morning, dear students. Today topic is the very important topic about the deep regions of the head, which are infratemporal fossa and pterygopalatine fossa, and some important spaces in the head and neck region that we are going to discuss. The first topic is infratemporal fossa. According to its name, the infratemporal fossa is the fossa which is below the temporal fossa. Where is the temporal fossa? Temporal fossa is located between the zygomatic arch and the bones of the skull, respectively the squamous part of the temporal bone, the temporal surface of the greater wing of a sphenoid bone, parietal bone, and some part of the temporal bone. And from these bones in the medial aspect and zygomatic arch, if you go down, you will reach to the fossa, which is located here, and it's called infratemporal fossa. To understand this fossa better, you can see this outline of this fossa, which is here, and the best landmark that you can find it, you can find the lateral border, which is the ramus of the mandible, and around this ramus of the mandible is, you can find this infratemporal fossa. It's more or less is a wedge-shaped fossa, and the details border of this fossa are following. The superior border or roof of this fossa is formed by the infratemporal surface of the greater wing of a sphenoid bone. As you know, through this greater wing of the sphenoid bone in the infratemporal fossa, there are opening two foramens. There are oval foramen and spinosum. And also at the temporal bone, you have another fissure which is called petrotympanic fissure. Those are very important, that if you know that this fossa and fissure and this opening, that I suppose that you are expert in the opening of the skull, so and you know what the structure they are past, so now you can somehow connect this information that you have it, that the content of the infratemporal fossa is what, and the content of the pterygopalatine fossa, it's what structure. So one by one we are going to discuss. The medial wall, it's the lateral plate of the pterygoid process, anterior in ventrally, and also the two muscles of the soft palate, which is tensor veli palatini and levator veli palatini, and also the wall of the pharynx. They are the medial aspect. The ventral aspect is the tuber maxilla, the maxillary tuberosity, which is containing the foramens and canals, the posterior superior alveolar foramens and canal, and also a small part is communicating with the orbit through the inferior orbital fissure. The lateral wall, it's, as we said, and here is removed because to see the infratemporal fossa is the ramus of the mandible and the two processes that it has, the condylar and coronoid process. The dorsal border is a styloid septum. Styloid septum, it is a group of the muscles that they are attaching to the styloid process of the temporal bone. Sometimes they consider also the mastoid process and the structure that they are attaching to it in parapharyngeal space or lateral pharyngeal space. We are going to discuss what is a styloid septum. And finally, the inferior border, there is no border, so there is no floor. The infratemporal fossa down or caudally, it reaches to the place that the medial pterygoid muscle is attaching to the inner surface of the mandible, and it reaches to the submandibular region or submandibular gland. So those are the details of the walls of the pterygopalatine. Here you can, very nice, you can see the anterior and the medial wall of the infratemporal fossa. The anterior one is the tuber maxilla. The medial wall is the lateral plate of the pterygoid process with the tensor veli palatini and levator veli palatini, together with the pharynx, which is attaching to the external cranial base. Regarding the roof, as you see, this is the greater wing of a sphenoid bone, the temporal surface, and here is the crest, which is separating it as an infratemporal crest, and here is the horizontally the infratemporal surface of the greater wing of a sphenoid bone, which are two openings open here, the foramen spinosum and the foramen ovale or oval foramen, that you know that which structure they are passing it. Regarding the lateral wall of the infratemporal, we talked about the mandible, the details, so you know already, but here you know that the inner surface or medial surface of the mandible or the ramus of the mandible, together with the processes, the coronoid and condylar process, they are making the lateral wall of the infratemporal fossa. So it means that if I want to enter to the infratemporal fossa, I will cut this ramus of the mandible, and now I am inside the fossa from lateral to the medial. In the medial aspect of the ramus of the mandible, you have mandibular foramen, which pass inferior alveolar nerve artery vein, and near to that there is a lingula, the small tongue-shaped projection, which is the place for the attachment of the one of the ligament of the temporomandibular joint, is the sphenomandibular ligament. And in inner surface also obliquely it's passing a groove which is called mylohyoid groove, which is the place that the mylohyoid nerve and sometimes artery and vein also they are passing through this groove. And finally, in the angle of the mandible, here is the roughness, which is the medial pterygoid, the pterygoid tuberosity, which is the place for attachment of the medial pterygoid muscle. That all of this information we are already discussed. Then the content. The content of the infratemporal fossa is the biggest or largest content is lateral and medial pterygoid muscle. Here is cut edge of the lateral pterygoid muscle, and here the superficial and deep head of the medial pterygoid muscle. Then it's the tendon of the temporalis muscle, which is coming down and is attaching here is cutted, attaching to the coronoid process, and is continuous as a temporal crest. Then to understand the content of the of the infratemporal fossa is enough to again think. We said that in the roof, which is the infratemporal surface of the greater wing of a sphenoid bone, two openings is open. What are they? Ovale and spinosum. Through the foramen ovale, now you know that what the structure pass? Mandibular nerve. So immediately you can say that the mandibular nerve is one of the content of the infratemporal fossa, logic, yes? And then when you learn the branches of the mandibular nerve, somehow this mandibular nerve is giving several branches that we are going to discuss, is a content of the infratemporal fossa in some extent, yes? Another structure that it passed through the foramen ovale is accessory medial meningeal artery, and also emissary vein. Emissary vein, which is connecting extracranial vein, in this case is the pterygoid venous plexus, to the intracranial vein, which is the cavernous sinus. In a while we are going to discuss. So the pterygoid venous plexus is the content of the infratemporal fossa because it's immediately under the oval foramen, yes. Then you know that through the foramen spinosum it passes middle meningeal artery, and the meningeal branch of the mandibular nerve, or the current branch of mandibular nerve. So medial meningeal artery is the content of the infratemporal fossa, which is arising from the maxillary artery. So the maxillary artery, the first and second part, is the content of the, like this, if you think, is easy to understand the content of the infratemporal fossa, since you know which opening is open where and where. Another content is one of the parasympathetic ganglion, which is called otic ganglion. I talked about this in the salivary gland, in parotid gland. Otic ganglion is responsible for innervation of the parasympathetic innervation of the or secretomotor innervation of the parotid gland. The synaptic or the paraganglionic fiber of the parasympathetic fiber of otic ganglion is coming from the tympanic branch of the glossopharyngeal nerve, and postganglionic via the auricular temporal nerve is branch of mandibular that we are going to discuss. The maxillary artery, we said maxillary artery, which is, as a matter of fact, is branch of external carotid artery when it come inside the parotid gland. The external carotid artery, it gives the superficial temporal artery 1 centimeter in front of the external acoustic meatus approximately, together with vein and auriculotemporal nerve. And also inside the parotid gland, it gives it the maxillary artery, which is going behind the neck of the mandible, and it's going to the pterygopalatine, to the infratemporal fossa, and finally it enters to the other fossa, which is called pterygopalatine fossa. So the maxillary artery, it has a course from to infratemporal fossa, and then it ends to the pterygopalatine fossa. That's why the course of the maxillary artery is divided to 3 parts. The part that is behind the ramus of the mandible, which is cutted here, it's the mandibular part, or sometimes it's called first part. The course that is going between the medial and lateral pterygoid muscle is called pterygoid part. And then the course that it enters to the pterygopalatine fossa that we are going to discuss through the maxillary fissure is called pterygopalatine part of the maxillary artery, or the third part of the maxillary artery. And all the branches of the first part and second part of the maxillary artery is inside the infratemporal fossa that we are going to discuss. Another structure is the pterygoid venous plexus that we said. Its content, chorda tympani, the princess chorda tympani is the nerve, is the branch of fascial nerve. Also is the content we are going to discuss. A part of parotid gland, it reached the deep part of the parotid gland, it reached to the infratemporal fossa. The corpus adiposum, or adipose body, which is coming from the temporal region down to the buccal region, is the content of the infratemporal fossa. And finally, some literature, they write that the sphenomandibular ligament also is a content, and it's true because it's attached to the lingula, which is in the inner surface of the mandible. So now I will leave all this content that we mentioned it, and the highlight, it's the topic that we are, or the content that I will tell you some details about this. The first one is the sphenomandibular ligament, is one of the extracapsular ligament of the temporomandibular joint that originated from the angular spine, or the spine of the sphenoid bone, and is inserted to the lingula. And this is the content of the infratemporal fossa. Another content that is the largest content is the lateral and medial pterygoid muscle. This lateral and medial pterygoid muscle, you know it already. We said it several times in TMJ, that the lateral has superior head, inferior head, the medial had the deep head and superficial head. and where they are attaching the superior head to the disc and articular capsule of the TMJ, inferior to the pterygoid fova of the neck of the mandible. For the deep and superficial head is attaching to the medial pterygoid muscle. They are attaching to the pterygoid tuberosity in the inner surface of the angle of the mandible. And here you have the details of this, these two muscles that we already discussed it in TMJ, and the details you have it, and here you have it again. Another very important component of the, or content of the infratemporal fossa, as we mentioned, it is mandibular nerve that is coming immediately from the oval foramen, which is logic, that is open to the infratemporal fossa, so is the content. And it gives several branches that we are going to discuss it. So the branches of the V3, or the mandibular nerve, they are classified as a two-part. One is the motoric innervation, because the mandibular nerve has motoric function and also sensory function. The motoric function, it must innervate, or somatomotoric function, it must innervate the muscles. So you know that already, that the muscles of the mastication, they are innervated by mandibular nerve. So the anterior-posterior deep temporal nerve, the masseter nerve, the nerve to the lateral and medial pterygoid muscle, and together with the two other muscles like a tensor veli palatini, the muscles of the soft palate, and tensor tympani, the muscles of the middle ear. So they are also innervated by the mandibular nerve. Together with Tuesday, we said that the anterior belly of the digastric muscle and mylohyoid muscle also is innervated by mandibular nerve. The sensory innervation, they are meningeal or recurrent branch that it passed through the foramen spinosum, auriculotemporal, which is here, the inferior alveolar, that now you know it, that it's passing through the mandibular foramen, is going to the canal, and it's coming as a mental foramen, as a mental nerve. The passage is between lateral and medial pterygoid muscle. Then very important, approximately 1 centimeter in front to it is the lingual nerve, which is a sensitive nerve. We said it for the anterior 2/3 of the tongue, the somatosensory innervation. And also we have a buccal that here is not, but we'll show it in the next slide, that this buccal nerve, which is here, it's passing between the superior and inferior head of the lateral pterygoid muscle, and then is descending down and usually is perforating the tendon of the temporalis muscle, which is attaching to the coronoid process and the temporal crest, and then it going to the lateral aspect of the buccinator muscle. Be careful that the buccal nerve, which is a branch of mandibular nerve, it does not innervate buccinator muscle. Is pure sensitive or sensory nerve. It's just innervating the sensitive innervation of the cheek region, the skin, and the mucous membrane of the cheek region. As you know, the buccinator muscle is classified as a mimic muscle, and mimic muscles, they are innervated by fascial nerve. So this 5 branch that you have it, it's one of them, it was buccal branch of the fascial nerve from the parotid plexus or intraparotid plexus, which is responsible for the motoric innervation of buccinator. So buccal nerve, logic, you think immediately that, okay, it must innervate buccinator, is not, is just have a sensitive fiber. And finally, the lingual nerve that we discussed it Tuesday for the innervation of the tongue and the lower lip and the floor of the mouth. Already it's joining with the chorda tympani nerve, is a branch of the fascial nerve. I have a love story of the chorda tympani and the lingual nerve. In next semester, if there is a time, I will tell you their love story. And then it's passing through the lateral surface of the medial pterygoid muscle. It enter to the oral cavity. This is the chorda tympani that is coming from the descending part of the fascial nerve or fascial canal, and it's coming out through the petrotympanic fissure together with, thank you, anterior tympanic artery. So, and then this chorda tympani, I call her Princess Chorda tympani, then she fall in love with the very attractive nerve, which is the lingual nerve, and it's coming close and close and close, and it's synapsing with the lingual nerve. I'll tell you the very nice love story of them. Then when it synapses, so it gives, by love, the taste fiber that it has and the parasympathetic fiber that it has. So the taste fiber of the chorda tympani is carried by the lingual nerve, and it going to the anterior two-thirds of the tongue. That Tuesday we said the taste innervation of the anterior two-thirds is by chorda tympani originally from the fascial, and the somatosensitive by lingual nerve originally from mandibular nerve. And also it gives the parasympathetic fiber, which is going to the lingual nerve, and it's sending via the submandibular ganglion, is another parasympathetic ganglion, which is responsible for innervation of submandibular gland, sublingual gland, and the small salivary gland of the floor of the mouth and lip. So under the oral fissure, so you have all the glands, it's by the submandibular gland, and the source is the chorda tympani. It's very important, the injury of the lingual nerve, that it's a very risk factor for if you have experienced that your dentist removed the wisdom teeth, lower teeth, is a high risk to damage the lingual nerve, because it has a very close relation between the lower wisdom teeth and the lingual nerve. So definitely the surgeon must pay attention to this nerve, because if this nerve is damaged, if proximal, where the chorda tympani is joining to the infratemporal fossa, in this case, it was here that in this case the lingual nerve or the patient is losing the general sensation of anterior two-thirds of the tongue, oral mucosa, gingiva, and lower lip and chin. But if the lingual nerve lesion is somewhere distally to the site of the joining of the chorda tympani with this nerve, then additional of this losing, it's also the patient is losing the secretion of the salivary gland, and it's losing the taste of the anterior two-thirds of the tongue. So that's why it's important that the lesion of the lingual nerve, if it is before joining the chorda tympani with lingual nerve or after joining of the chorda tympani with the lingual nerve. We talked about the maxillary artery. We said that is one of the terminal branch of the external carotid artery, which is arising inside the parotid gland, and it's passing between here is cutted, the neck of the mandible and the sphenomandibular ligament. So as you see, it enter to the to the infratemporal fossa as a mandibular part or first part, and then it's going between the superior and between the lateral and medial pterygoid muscle is the second part, and then finally it enter to the pterygopalatine fossa as a third part or the pterygopalatine part. This first part and second part or mandibular part and the pterygoid part of the maxillary artery, which is located inside the infratemporal fossa, totally they give 11 branches that you have to know, and one of them that is familiar with you, as you see, is here, is the medial meningeal artery. And now you know that the medial meningeal artery is coming from the first part of the maxillary artery or mandibular part. And always be careful in any picture that you saw that the medial meningeal artery is going through the window or the loop that is formed by one nerve. This nerve is auriculotemporal nerve, which is branch of mandibular nerve. And through this loop or window, it passes this artery is medial meningeal artery. And as you see, it's entered to the foramen spinosum, to the medial cranial fossa. So this is important. Another important of this branch is inferior alveolar artery. Inferior alveolar artery, again, be careful. A lot of students, they do mistake. Inferior alveolar nerve is branch of mandibular nerve. But inferior alveolar artery, we said it also before, is a branch of maxillary artery. There is no mandibular artery. Yes, so this is the mistake that you are doing. So, but this is from mandibular part of the maxillary artery, or the first one, it goes to the mandibular foramen canal, and it ends up as a mental artery. The other branches, here you can see how the maxillary artery is going behind the neck of the mandible. This is the view from internal view, and the sphenomandibular ligament. So this artery horizontally passing, and it's entering to the the infratemporal fossa, which is located here. There are some variation that if this artery is going superficial to the lateral pterygoid or deep to the lateral pterygoid, which is not an important part for you. But as we said, the first part and second part of the maxillary, they are passing through the infratemporal fossa. The first part or mandibular part, it gives 5 branches. Deep auricular, anterior tympanic, medial meningeal, accessory medial meningeal, and inferior alveolar. That till now you know 4 of them. Where does it pass? Anterior tympanic, petrotympanic fissure, medial meningeal spinosum, accessory medial meningeal foramen ovale, inferior alveolar mandibular foramen. The pterygoid part is between the medial and lateral pterygoid muscle. To remember, it's supplying mainly the masticatory muscle. So if you know 4 masticatory muscle, so then you know that anterior and posterior deep temporal artery for temporalis, masseteric artery for masseter, and artery to the lateral medial pterygoid muscle. In addition of that, there is a buccal artery. The buccal artery, it has the same pathway of the buccal nerve, and it's going to the cheek region, and it's innervating the is blood supplying of the responsible for blood, supplying the cheek or buccal region. And here it's the first 2 branch of the maxillary artery, which is from the mandibular part behind the head and neck of the mandible. They are passing, and it has very close proximity with the temporomandibular joint. They are the deep auricular and the anterior tympanic. The anterior tympanic goes to the petrotympanic fissure, place that the chorda tympani is coming out. So during the operation in the TMJ, they have to be careful of these 2 small arteries that it can make the bleeding. And this is very nice. This is a sexy picture of the maxillary artery, as you see, and it's very nice. You can see the medial meningeal artery that is passing through this loop of the nerve, and this nerve is auriculotemporal nerve that we said that is whenever you see a loop, it's from the nerve, it's the auriculotemporal nerve, which is a branch of mandibular nerve. And whenever the artery you pass through that, it's the medial meningeal artery. And here is very nice. You can see the mandibular canal to the mandibular foramen and mandibular canal. This is the inferior alveolar artery, and those are the continuation of the maxillary artery till it reaches to the pterygopalatine fossa. Next content is the pterygoid venous plexus. We talked about this so often because it's similar to the branches of the maxillary artery, but in vein we don't have all this branch of maxillary artery. They make a plexus, and they call pterygoid venous plexus. And as we mentioned that, it's through the oval foramen via the emissary vein. It's connected to the middle cranial fossa, to the cavernous sinus, which is intracranial vein, which is extremely important for the spread of infection, and also it's for the spread of the metastatic cells. Normally, this plexus is located between, again, the lateral and medial pterygoid muscle. Yes, and this plexus, as we mentioned it, is important as a spread of infection or metastatic cells. We said that if you want to apply the block anesthesia to the tuber maxilla or maxillary tuberosity for the block anesthesia of the posterior superior alveolar nerve, here you have to be careful of this plexus. That bleeding of this plexus can cause a lot of edema or the hematome. And what is important is that the pterygoid venous plexus, it has a connection posteriorly or dorsally via two small vein, which are maxillary vein. Usually there are two. They are connected to the retromandibular vein, and then the retromandibular vein is divided to the posterior division, which is draining to the external jugular vein, and the anterior division, which is draining to the common fascial vein or internal jugular vein. So this is the communication of this plexus to the dorsally. This plexus also ventrally, it's communicating with the fascial vein, and fascial vein is communicating with the deep fascial vein or common fascial vein, and then finally it's draining to the internal jugular vein. Why is important, and why you know that, for example, through foramen ovale, it passed emissary vein, which is connecting extra and intracranial vein. And why you have to learn that why the pterygoid venous plexus dorsally is connected with this vein, and anteriorly is connected with the fascial vein, and fascial vein is connected, as you see, as an angular vein. It's the connecting with the superior ophthalmic vein, which is passing through the superior ophthalmic fissure or superior orbital fissure. It's draining to the cavernous sinus. Or it's connecting the fascial vein with the inferior ophthalmic vein, which is passing through, now you know that it's passing through the inferior orbital fissure, and is somehow is connected with the superior one and is connected with the cavernous sinus, or it's connected with the pterygoid venous plexus like this. This is clinically important. And when I reach to this place, I have to tell you that, for example, in the face region, there is a danger triangle of the face. This danger triangle, it's this area, for example, that it's connecting the angle of the mouth together, and the apex of this triangle, it goes to the root of the nose. Yes. And it's an area that is, your nose is there, your upper lip is there, your part of maxilla is there, and they call it danger triangle of the face. Why? You have, maybe you are used to, especially the girls, then morning they wake up and they go to the mirror and they see, oh, some pimples are there, yes? And they start to press it, yes? Don't do it. Boys also, they are doing. Don't do it. If you press it and the pus coming out, you win. But if you press and the pus, instead of going out, it's going deep to the venous system that I show it to you, then the infection, it goes to the venous system. Via this connection through the foramen ovale, to the pterygoid venous plexus, to the cavernous sinus, to the fascial vein, to the superior ophthalmic vein, to the inferior ophthalmic vein, to the cavernous sinus. And this is 17 years old girls that died because of this. Why? Because he spread it to the fascial vein, it went to the pterygoid venous plexus, is connected with the ophthalmic veins, and via the oval foramen, emissary vein, it goes to the cavernous sinus, and boom, brain abscess. So it cannot be only the skin, it can be teeth. That's why when you tell the patient that you can die from infection of the tooth, he will laugh at you. You say that, oh, he's crazy or something, but it happened. It can be ear, it can be eyes, it can be nose. This spread of infection through the venous system, it's very dangerous, and it can cause thrombosis in the ophthalmic vein, thrombosis in the cavernous sinus. And since later we can say that in the cavernous sinus, they are passing a several structure, cranial nerve number 3, 4, 6, V1, V2, internal carotid artery, they are all passing through the cavernous sinus, and if come infection there, and thrombosis and brain abscess, then you have the consequence of this preorbital here. So be careful of this triangle of the face. Then connection of the pterygoid venous plexus in the part of the temporomandibular joint, which is called Zenker retroauricular plastic pad, and it has very important function for the movement of the mandible. So to make it easy, just to remember that when you open the mouth and the mandible is going forward and rotating forward and down, then this Zenker, retroarticular Zenker plastic pad, it's filled by the blood, by the negative pressure that it's happening between the capsule of the TMJ and the external acoustic meatus. By closing the eye, the head of the mandible is going back, is pushing this plastic pad to make it empty, and from the emptying of this blood, it going to the retromandibular vein through the maxillary vein, that in a chapter of the TMJ also we said it. The otic ganglion, which is located exactly under oval foramen. So if you want to find otic ganglion, which is a parasympathetic ganglion, it's exactly below the foramen ovale and medial to the mandibular nerve. And as we said, it's the parasympathetic ganglion which is responsible for the secretomotor or parasympathetic innervation of the parotid gland via the postganglionic fiber, which is auriculotemporal nerve. So this is the auriculotemporal nerve. As you see, it's a branch of the mandibular nerve which is carrying the postganglionic to the parotid gland, and here is the otic ganglion. The periganglionic, as we said, is branch of tympanic nerve, branch of the glossopharyngeal nerve. And here is the most of the content that we already mentioned here in this area, which is called infratemporal fossa. The inferior alveolar nerve, the lingual nerve, the buccal nerve, the maxillary artery, mandibular nerve, the pterygoid muscles, all are the component of this infratemporal fossa. So the communication of the infratemporal fossa is also very important and extremely important to explain how the infection from this fossa can spread to the neighborhood structure. Yes, so ventrally and caudally it's going down because there is no border, so it reached to the submandibular region. So suddenly you can have submandibular abscess. Laterally, from the maxillary tuberosity from the outer surface of the buccinator muscle, it can go to the buccal region. So patient have buccal abscess. The medially, it's continue because we said that the infratemporal fossa, if you continue ventromedially, you will reach the pterygopalatine fossa. So this transitional place between infratemporal fossa and pterygopalatine fossa, there is very important fissure which is called pterygomaxillary fissure. Also, from the infratemporal fossa through the foramen spinosum, you know, we said several times the middle meningeal artery bleeding, it can cause the type of the bleeding or hematome, which is called epidural. Yes, so it's connected to the epidural space, which is located in the middle cranial fossa. Through the inferior orbital fissure, then the infratemporal fossa is communicating with the orbit, so it goes to the orbit. Through the oval foramen and pterygoid venous plexus, we said it already, it goes to the cavernous sinus or middle cranial fossa, and finally, superiorly, it's going to the temporal fossa. So those are the communication which is extremely important to understand how the spread of infection is happening in this area.